Alright, our first question is outline the effects of liver failure on the effects of drugs, kinetics and dynamics. So basically, our structure would be PK, which is the ADME, and then PD, which is specific to the liver. And I'll just have a summary diagram here: hepatic encephalopathy, coagulopathy, hepatotoxicity, and hepatorenal syndrome. So, in terms of A, you talk about absorption, you need to remember that there is reduced biosynthesis, reduced absorption of fat soluble drugs. Then you also have portocable shunting, which decreases first pass metabolism and increases oral bioavailability. This is really important to realize that oral bioavailability and first pass are opposite. And portocable shunting is a shunting that is done as an operation to treat any liver failure. Then you have distribution. Remember our mnemonic was COPS, so C, O, which is cardiac output. So cardiac output or hyperdynamic circulation, because you have an increased cardiac output with cardio with hepatorenal syndrome, until it's severe. Initially get an increased cardiac output to compensate for the portal hypertension, later reduced cardiac output when cirrhosis and no compensation. Then COPS, so you have P, and that P is for pH, and we have another P, and we have S. So S is special population, which is body composition, and so you get fluid overload, increased VD, and you get drugs. Then there's another P for protein binding. So protein binding, you have reduced albumin, reduced oncotic pressure, fluid overload, ascites, so increased VD, and you also have reduced albumin or reduced alpha 1 glycoprotein, and you have reduced protein binding, increased unbound drug, but also increased clearance. So note that alpha 1 glycoprotein and albumin are different. This is more an acute phase reaction. I guess in an acute injury you would get that increase, but in here you would get it reduced. So it's mainly increased in obesity. Then you talk about metabolism. So there's nothing to talk about pH, so we haven't talked about it, but in the renal you get renal acidosis. Metabolism, hepatic metabolism, so obviously reduce phase 1 and phase 2 metabolism. Phase 1 is affected more than phase 2, and so you get enzyme CYP450 damage, i.e. low HER drugs are affected more because they rely on phase 1 intrinsic clearance. And they also rely on the protein binding or the unbound fraction. And increased drug concentration, and then you have more likely to get toxicity. HbF, reducing HbF would mean reduced clearance of high HER drugs. And that's more, the HER drug, the high HER. And then pseudocholinesterase. So remember our mnemonic for metabolism is HSP. So the mnemonic that we have was COPS having HSP, and then they're asking Siri. I don't know, it doesn't make any sense, but that's how you remember it. H is for hepatic metabolism, S is for cirrhosis, it's not that relevant, but I always forget cirrhosis, and P, I always forget P, which is pseudocholinesterases. So pseudocholinesterases decrease synthesis, decrease metabolism of SAX ester LA. And this is just a side note where HER greater than 0.7 perfusion limited, HER less than 0.3 is based, is capacity limited. Based on intrinsic clearance and protein binding, not HbF. Then you talk about elimination. So that's renal excretion. So that's where the hepatorenal thing comes. Decreased renal excretion, example morphine, M3G and M6G. So you can get accumulation. And whenever you talk about clearance, you have to talk about biliary clearance. So biliary excretion, reduced biosynthesis, reduced bioexcretion, example ROC or VEC. here, so VEC has 60% biliary clearance. Remember, it's 20, 40, 80 in the urine, renal clearance, and then biliary clearance is 80, 60, 20. Oh, that's rec, VEC, and pancreas. And then the last thing you do is drug sensitivity. So our mnemonic for drug sensitivity was Siri. Now, I don't know if it applies here. Let's check. So S was for I was for drug interactions. R was for receptors. I was for idiosyncrasies such as anaphylaxis. S was for S was for sensitivity. So we have here drug sensitivity, hepatic encephalopathy, so increased sensitivity, so that works. Coagulopathy, additive effect with anticoagulant, antiplatelets, so I guess it's interaction of drugs. Increased risk of hepatotoxicity with drugs, so that's again the interaction of drugs. Hepatorenal syndrome, increased susceptibility of nephrotoxins, so I guess it's idiosyncrasies. So idiosyncrasies, drug interaction, sensitivity, and then receptors, not really, but yeah. And then this is just for understanding, a diagram that shows the hepatorenal syndrome. So you get a filament liver damage, you get portal hypertension, then you get vasodilation, and with nitric oxide, that causes increased cardiac output. And then you get hypotension, because you have reduced return mean systolic filling pressure, so return, so you get hypotension, and so that's why it affects the kidneys. And then you get the vasoconstriction of the efferent, hypertension in the afferent, and then you get RAS, and then you basically get fluid overload, so you get ascites, so, and then you get portal hypertension and so on. Okay.